So in this first lecture on the thyroid gland, we're going to look at the general location and structure of the thyroid, look at the blood supply, lymph and nerve supply, the microanatomy of the thyroid, and then I'll say a bit about the embryologic development. So in terms of location, the thyroid is of course in the neck. It's a butterfly-shaped gland. It lies lies on the anterior surface of the trachea, just below the laryngeal cartilage, or the Adam's apple, and it's at the level of around C5 to T1, so kind of stretches in that direction. So if you look over at the diagram here, here's the hyoid bone, here's the Adam's apple on the laryngeal cartilage. If you slip your finger down from the laryngeal cartilage onto the first ring of the trachea, right below that there will be a soft fleshy area that's called the isthmus of the thyroid, and then there are two lobes that extend on either side there. So it's actually a lot lower than in the neck than a lot of people think. I've seen some people try to palpate the thyroid way up here by the hyoid bone, but it's actually lower than the Adam's apple on either side. It's of course surrounded by a couple of really important structures. So one would be the carotid artery. So the common carotid, before it bifurcates, will pass on either side of the thyroid. And then there's an important nerve, which would be the recurrent laryngeal nerve, which is a branch of the vagus nerve that we'll talk about. Before I go on, I'll just say on the back side of the thyroid, if you peel the thyroid off of the trachea, you generally find 4, sometimes people have 5 parathyroid glands, and they're separate glands embedded in the thyroid tissue. And what's important about that is they actually have their own blood supply, nerve supply, and they're sort of individual, separate from the thyroid. And so a very common disorder is a parathyroid adenoma, where it overgrows, it oversecretes parathyroid hormone, which is its main secretion, and surgically that could be removed without damaging the rest of the thyroid. So thyroid's bilobed. Each lobe is about 5 centimeters in length. It's about 2.5 centimeters in width, and it's connected by an isthmus that falls between the second and third cartilage rings on the trachea. It's one of the larger endocrine glands in adults. It weighs about 25 grams, usually larger in females, especially during pregnancy, because of the increased need for thyroid hormone for the fetus. It first becomes functional in early fetal life, because in the first trimester in particular, the fetus still has not adequately developed its thyroid, so it requires maternal thyroid hormones for proper development. As we'll see, thyroid is extremely important for nervous system, central nervous system development in the brain, for example. The parathyroid glands I spoke about, the recurrent laryngeal nerve passes through, and it's not actually depicted on this picture, but I'll show that in the coming slide. But basically it's going to pass, there's 2 branches that are going to go through the thyroid gland on their way to the larynx and the voice box. And this is significant because any compression of the recurrent laryngeal nerve will then result in hoarseness or change in voice, just any sort of dysphonia. And that could be from an enlargement of the thyroid, like a goiter. It can also be from lung tumors and esophageal cancer in some cases, things like that. But in this case, a compression of the nerve by the thyroid could result in chronic hoarseness. So that's always something that we investigate. One of our, for chronic hoarseness, we usually send for an ultrasound to sort of evaluate to see what all these structures are doing. Mentioned the common carotid arteries on either side of the thyroid. Again, this can be significant because as the thyroid enlarges, it can start compressing on the carotids, and that could actually form a bruit. The thyroid arteries also can become compressed, and those can be heard with the stethoscope, or some patients will actually hear with thyroid enlargement sloshing in their ears, and that's from the compression of the arteries. And then the sternocleidomastoid lies on either side of the thyroid. Now the functional unit of the thyroid is the follicle, and the follicle itself actually consists of a number of different cells. So basically it's a little structure with epithelial cells, thyroid epithelium, and then on the inside of the follicle there is protein that collects water, and that's a colloid. So there's a core of colloid, and the colloid is made of thyroglobulin, which is an iodinated glycoprotein. It's very rich in tyrosine, so that's why tyrosine will actually be the precursor for thyroid hormones. The follicular cells, when they're activated by TSH from the pituitary, the anterior pituitary, that'll bind to receptors on the epithelium, and they will release T4 primarily, about 80%, and about 20%, 15% T3. The T4 is considered to be inactive thyroid hormone. The 4 indicates there are actually 4 iodine groups attached to it. The T4 has to be deiodinated. One of those iodines has to be removed for it to become active T3. And that happens primarily inside the cells once the thyroid is transported to the cells by enzymes called deiodinases. And so we'll look at that in detail. But that's a further step of regulation of the thyroid. So that's the kind of functional unit. We'll delve into that here in a little bit. The thyroid itself is covered by a fibrous capsule that has 2 layers. So this is the thyroid capsule. There's an inner or true capsule layer, and it actually divides the thyroid into little segments called septa, and it divides the thyroid into lobules. So each lobule is kind of like an independent functional unit in the thyroid. There's an outer capsule, the false capsule, and that's derived from pretracheal fascia. That's part of the deep cervical fascia. And there is a thickened portion of the false capsule that's called the suspensory ligament of Berry, and it connects the medial surface of the lateral lobe to the cricoid cartilage, so it kind of extends up to the cricoid. And that helps to move the thyroid up and down with swallowing. So that's why when we have patients swallow during thyroid exam, that can actually tell us a bit about the mobility of the thyroid and so forth. Here is another picture of the thyroid from a cross section. So this is showing the trachea here, the opening to the trachea. Here is the voice box, and then here is the laryngeal pharynx up here. And then on either side is the thyroid cartilage. Here you see the thyroid in cross section, not showing the isthmus here, which would be down here. And then here's the suspensory ligament. Here's the cricoid cartilage. So it's kind of buried under the thyroid, so I can't really see it in that picture down below that I just pointed. And the suspensory ligament actually connects the thyroid to the cricoid cartilage. So that's the kind of general outer anatomy of the thyroid. A couple of interesting anatomical variants. So one is some people actually have a third lobe called the pyramidal lobe or Lalouette's pyramid. And that is in up to 45% of people, and that's shown here in this picture to the right. You see here's your normal lobe, your typical lobes, and then here is a third lobe. And that has to do with the fact that, as we'll see embryologically, the thyroid begins higher up, actually as part of the nasal mucosa, and then it moves, or the oral mucosa, and then it moves down, migrates to its final position. And so this third lobe is actually a remnant of that embryological migration. It's often functional, creates no extra problems. In fact, it's sort of like a backup lobe in case you need extra thyroid. The levator muscle of the thyroid gland connects it to the hyoid bone. So the hyoid, remember, is up in this diagram. It's up here. So the levator muscle will connect it to the hyoid bone. Again, that gives it another suspensory ligament or suspensory system to kind of hold it in place in the neck. And there is, some people have an anatomical extra artery. It's called the thyroid imma artery. I'll show you that here coming up. So that's some of the external landmarks of the thyroid. In terms of blood supply to the thyroid, there's arterial supply, which comes from the external carotid artery, and that's the superior thyroid artery. And then there is an inferior thyroid artery, which is a branch of the thyrocervical trunk. So if you look at the carotids here, superior thyroid artery comes off the top, and then we have an inferior artery that comes off the bottom here. So here's the thyrocervical trunk. And so that is basically, those are the two major supplies. Again, there's a third variant, the thyroid imma artery, which is shown here in this picture, kind of coming off and feeding the front of the thyroid. So basically that's going to kind of give blood supply to the isthmus. And again, not everyone has that. Usually it's the superior inferior thyroid arteries that are predominant in most people. The clinical significance here, of course, is that thyroid enlargement, any goiter, can compress those thyroid arteries, and that can give rise to the bruit, which would, of course, be an audible whooshing sound, or in some patients, it could be large enough to produce a palpable vibration on the skin. That's the thrill. So bruits and thrills could be consequences of goiter. The venous drainage would be through the superior and middle thyroid veins, which drain straight into the internal jugular, and then the inferior thyroid veins, which drain into the left and right brachiocephalic veins. So that's shown down here. So pretty simple circulatory supply to the thyroid. The significance of thyroid blood flow can come into function. If there's increased blood flow to the thyroid, that could actually increase all the nutrition needed and the amount of TSH and whatnot that reaches the thyroid. So that could impact the amount of thyroid hormones secreted. So it's a little paradoxical. We'll look at the autonomics, which regulate the arterial supply here in a moment. Generally, increased sympathetic tone, although it might vasoconstrict a little bit, tends to increase the secretion of thyroid hormones, and that would increase peripheral metabolism as well. So it sort of supports thyroid activity, whereas the parasympathetics most likely dilate the thyroid arteries, but they seem to have more of a slowing down effect on thyroid metabolism. So it's a little more complex with the autonomics and thyroid. From a more traditional medical perspective, for example, in Chinese medicine, there's something known as the yang and the yin function. Yang is, for example, increased heat, metabolism, and so forth. Well, the arteries would essentially fuel that yang aspect. They increase the metabolism of the thyroid, versus the veins would actually drain away any inflammatory metabolites, and they would have a cooling, more what we'd say yin effect on the thyroid gland. And then there is lymphatic drainage, and that's going to pass to the prelaryngeal lymph nodes. That's just located above the isthmus of the thyroid, and then into the pretracheal and the paratracheal lymph nodes. So with any sort of advanced thyroid cancers, they're going to spread through the lymphatic system. We'll talk about the different types later. Some of them spread more to the blood, others spread to the lymphatics. But that would be important for palpation to see if there's any large nodes around the thyroid. In terms of the nerve supply to the thyroid, again, we have both parasympathetic and sympathetic stimulation. The parasympathetic is via branches of the vagus, and the superior laryngeal nerve. This also innervates the cricothyroid muscles. And this injury to that nerve can cause a change in the pitch of the voice or the inability to make explosive sounds to sort of emphasize the voice. Versus recurrent laryngeal nerve, that's the one that's going to be more commonly affected with bruits and whatnot. This supplies the intrinsic muscles of the larynx. And so these are and also the primary innervation to the vocal cords. So any damage or injury, compression, etc. there would be more noticeable in hoarseness, aphonia, or even dyspnea, shortness of breath. And that can be injured by trauma, surgery, any sort of tumor spread. I talked about lung and esophageal cancers, and so forth. Part of the real challenge of thyroid surgery, like thyroid removal, maybe removal of even a part of the thyroid or the parathyroids, would be damage to the recurrent laryngeal nerve. Fortunately, the incidence is quite low of that with better surgical techniques, but it's still up to 3% of damage in thyroid surgery. Possible actions of the parasympathetic nervous system, it's still an area that received a bunch of research back in the 80s and before that, and then I haven't seen a lot of more recent literature, but from what we know so far, the parasympathetics vasodilate the thyroid arteries. That increases blood flow, and that seems to increase more release of thyroid hormone. It's unclear if that results in maybe more proportion of T3 or more effects on metabolism downstream. With the sympathetics, that innervation is from the superior, the middle, and the inferior cervical ganglion of the sympathetic trunk. So that's all up in the sympathetics in the neck. And we think that this, again, increases secretion of thyroid hormones, as well as the activation of the sympathetics in general, increase the peripheral metabolism of thyroid hormones. So we can think of this polarity between more sympathetics related to the actions of metabolism, speeding up metabolism, but also consciousness. So if we think of the polarity between consciousness and your metabolic life activities, the sympathetics, thyroid in a way supports that. So that's why thyroid has sort of we might call it a catabolic effect. It tends to prevent the buildup of excess water, excess tissue, excess fat, that sort of thing. Versus the parasympathetics are more supporting your anabolic activities. So we can think of sympathetic thyroid more catabolic, parasympathetic more anabolic, kind of working in opposition to that. So next, let's zoom in on the microanatomy of the thyroid. I mentioned before that the functional unit of the thyroid is the so-called thyroid follicle, and that consists of a rim of follicular cells, which are epithelium. So here's a follicle depicted over here. So if you cut open the thyroid, you see, thousands of these little units, and between each follicle there are capillaries. That's depicted in the red here. And the capillary is going to bring in, of course, nutrition, oxygen, but also TSH that's been secreted into the circulatory system from the pituitary will reach the thyroid that way. And then when thyroid hormones are released, they're going to be released from those follicular cells into the capillary system. So each follicle has its own little blood supply. There are also, not depicted here, nerves and then even lymphatics, which drain away interstitial fluid around the follicle. And then inside the follicle is the colloid, which I mentioned is rich in tyrosine. It's iodinated tyrosine, and we call that thyroglobulin. So thyroglobulin is going to be important because in autoimmune thyroiditis like Hashimoto's, the immune system actually makes antibodies against thyroglobulin together with some of the other thyroid peptides. The follicular cells, they're epithelium. They again secrete the thyroid hormone. They have all the enzymes to prepare thyroid hormone from the thyroglobulin. Essentially, the process is going to be thyroglobulin is a giant peptide, thousands of tyrosine residues on a single peptide, and each is iodinated. When it comes time to make thyroid hormones, that peptide, the thyroglobulin, will be endocytosed into the follicular cell, and then there's different enzymes which will cleave it into the different thyroid hormones, T4, T3, together with a couple of others. And then those will be exported from the thyroid. So thyroglobulin kind of stores the pre-thyroid hormone, and then the follicular cells will break that into thyroid hormone itself. The shape of the follicular cells varies from cuboidal to columnar. Typically they're more cuboidal, and they have all sorts of special transporters, and one in particular is the sodium iodine symporter. And this essentially traps iodine from the plasma. It's going to concentrate it within the thyroid follicle. So that's why thyroid really concentrates iodine. There's some other tissues we'll see that concentrate iodine, like breast tissue, gastric mucosa, and that was thought to be the fact that thyroid iodine has a very antimicrobial effect. So any tissue that needs to be kept more aseptic is going to have more iodine concentrated into it. And that's one reason why we don't see many thyroid infections. Now there are a couple. There's actually an infectious thyroiditis, and that creates a very painful thyroid. But typically that's going to happen more in iodine depleted areas, not so much in people with normal iodine status. So the thyroid really can concentrate up to 30 to 40 times more the amount of iodine that's in the plasma. And then also scattered throughout between the follicles are what are called C cells. And the C cells secrete calcitonin. And calcitonin is going to work in opposition to parathyroid hormones, so PTH from the parathyroids. Its main effect is going to be to increase serum calcium, and it's going to do that by mobilizing from the bone, as well as increasing absorption from the GI tract, as well as preventing loss to the kidneys. Calcitonin is going to do the opposite. So calcitonin really tries to put the calcium back into the bone and decrease the serum calcium. The thing about calcitonin is we know in other mammals it's quite significant for calcium regulation, but it's debated as to how significant, because when people lose the ability to make calcitonin, they don't seem to have major problems with calcium regulation, versus with parathyroid removal, it's a major issue. We get severe hypocalcemia with all the consequences neurologically and muscularly from that. We do use calcitonin as a marker, though. There's four major types of thyroid cancer we'll look at, but one of them is called a medullary thyroid cancer, and that is a cancer of the C cells. And so calcitonin can be used as a tumor marker to sort of follow the progress of treatment and so forth. Here's a little blow up of the sodium iodide symporters. Again, they're found on the outside surface of the follicular cells, and they're going to basically bring in an iodide ion, that is I minus, together with sodium ion, both together, and then that will basically kind of maintain the intracellular concentration of the iodine. That iodine will then move into the colloid, where it's then attached to the thyroglobulin and the tyrosine that's in there. And the sodium will be, basically pumped out of the cell via sodium pumps. So that's how we maintain the gradient there. So that's the sodium iodide symporter. So the thyroid gland has an interesting embryologic origin. It actually comes from endodermal tissue in the pharynx, in the throat. Remember, endoderm gives rise to all of your GI epithelium, so your inner lining of your GI tract, your liver, pancreas, all the digestive organs, organs of metabolism, but also the lungs. And as we'll see, there's a real connection here with thyroid and the respiratory system. In fact, we can think of, I'll just mention it now, thyroid is kind of the so when we think about respiration, pulmonary respiration, that's really bringing in oxygen. It attaches to hemoglobin. We exhale CO2. That oxygenated hemoglobin now goes to the tissues where the oxygen dissociates, goes into the cells, and that stimulates aerobic metabolism. And that happens in mitochondria. Well, interestingly, thyroid hormone, one of its main roles is going to be to increase the number and the activity of mitochondria. So in a way, it's kind of taking that lung activity all the way down into the tissues. So we can think of thyroid as carrying the lung activity, and we can trace it all the way back embryologically to the same sort of tissue. The thyroid follicular cells actually arise from the midline, what's called the midline thyroid diverticulum, and that's just caudal in the embryo to what's called the first pharyngeal arch. Here we see the gut tube, that's all in yellow, and you see the bifurcation here into the esophagus and the trachea. Here is the so-called pharyngeal gut, it's going to become the throat. And here is here's the oral cavity. This is all going down into the gut tube, down further into the intestines. And the thyroid sort of develops here as a little outpouching, and that's going to actually migrate from this area called the foramen cecum, which is in the nasal or in the oral pharynx. And it's going to actually migrate down, and you see the path here in front of the hyoid bone, down in front of the thyroid cartilage, down to its position there. And I pointed out how the pyramidal lobe in some people is actually a remnant of that migrating thyroid. Well, unfortunately, in some people, this thyroid gland can actually, as it migrates, it can leave bits of tissue where it goes. And so that actually forms what are called thyroglossal cysts. And these thyroglossal duct cysts actually have a possibility of becoming infected or having other issues go on. I'll talk about that here in just a second. The parafollicular cells, the C cells, actually arise from the foregut endoderm, and that begins in the fourth pharyngeal pouch. So that's part of one of those pharyngeal arches. So the follicular cells descend via that thyroglossal duct to the anterior trachea, and then it bifurcates, forming the two lobes. The thyroglossal duct actually connects the thyroid to the tongue directly, and usually it degenerates by the 5th week of development, and then the C cells join the thyroid as the thyroid descends to its final location, and then we have the final migration of the thyroid. So sometimes you do have these duct cysts that remain, and these are portions of ectopic thyroid tissue. They can present anywhere along that thyroglossal duct, from the base of the tongue down to the mediastinum. And the cysts are typically asymptomatic, but they can become infected, and in some cases actually can become cancerous, resulting in thyroid tumors. And again, the pyramidal duct is a remnant of that, of the thyroglossal duct. So here you can see here's the base of the chin here, and then here's the typical location of the thyroid, and here's the thyroglossal duct. And in this person, you can actually see duct cysts actually have formed at different portions along that. So this might be something you might palpate in the midline. So this would be midline structure. If there are other structures on either sides, those could be actually cervical cysts, and those are remains of the pharyngeal cleft. So if you feel it more laterally, but not to the extent of where we have our lymph nodes by the sternocleidomastoid muscles, that would be a cervical cyst, most likely. So those are different than the thyroglossal duct cysts. All right, so that's a little bit about the embryologic origin of the thyroid. The fetus needs to be self-sufficient with thyroid hormones in order to really have proper brain and metabolic development, and and also to protect itself from, if the mother has hypothyroidism, then the fetus has to produce all those hormones on its own. So the fetal hypothalamus and pituitary start to secrete TRH, which we'll see that's the signal the hypothalamus sends to the anterior pituitary to release TSH, and that happens around 11 weeks gestation. And then by week 18 to 20, the T4 actually reaches a clinically significant and sufficient level. So that's when the thyroid becomes autonomous in the fetus. T3, which is the active thyroid, remains low until about 30 weeks of development, and then it increases. And obviously, the fetal thyroid needs adequate iodine to function. So here's just a little bit of a summary of the levels of fetal thyroid. So here's maternal T4, and so going at starting conception here, looking at week 12 roughly, that's when the fetal thyroid comes online, and you see that levels rise and now start to match and increase over the maternal thyroid. So where we're really concerned about fetal thyroid is especially in the first trimester, but also going into the second trimester. And so one of the things we really want to look out for in pregnancy is maternal thyroid hormone levels. We want to make sure that they're kept within the right ranges, and we'll discuss about what those ranges are a little bit later. Okay, so that wraps it up for the kind of general introduction to the anatomy of the thyroid. In the next video, we're going to jump into the actual thyroid hormones themselves, kind of look at what the different hormones are, how they're transported, metabolized, and then talking about thyroid receptors.